And I'd like to welcome everyone to this month's PFAnetwork virtual meeting. Thank you all for joining. I see some familiar faces. Great to see all of you. And hello to everyone in the chat box. Thank you for introducing yourselves and checking in. I'm excited to talk with all of you today and learn with all of you. We have some great opportunities for discussion in this month's virtual meeting. I am Lindsay Galley. I'm the Director of Education here at PFCC Partners. You may have seen me on a lot of the educational opportunities that we provide to patient family advisors through the PFAnetwork, the most current being Quality Improvement Basics for Advisors, which part 2 is happening at the end of this week. Also with me is Libby Hoy. Libby, do you want to say hello?
Hi, everybody. It's a pleasure to see you guys. It's always my favorite day of the month to have our PFA virtual meetings.
Definitely. Great. And just as a reminder for those of you who are new to Zoom, you should be able to see my screen if you're on the computer and see a bunch of faces on one side of your screen as well, which is great. I love to see all your faces. If you do have some background noise, like Libby mentioned, the construction they have over there, you can hover over your screen. It's either at the top or the bottom of your screen where you can find the toolbar that has the mute button. And if you would like to share your video or stop your video at any time, you can choose the stop video as well. And then if you have a comment throughout any of the discussion going on today, you can use the raise hand option. And you can find that by clicking Manage Participants and then raise hand right at the bottom, and we'll be able to see if you would like to speak up at any time. And also it looks like a majority of you have found the chat box, so that is wonderful. But if you haven't, it is also located on that toolbar, as well under chat. And feel free to post your comments and questions all throughout today's meeting. This is always a very interactive session, which I think is why Libby and I love it so much, because we get to talk to all of you. So that's wonderful. And here we are. We're a little dolled up in these pictures. I don't look the same there. But and there's Libby as well. And I'll go ahead and pass it off to Libby. Libby, you are muted because of that construction.
Lindsay, I will say that we have lost power in the office this morning, gotten it back on. So if I drop off, you are.
I'm actually going to go ahead and move it over.
Okay.
All right. Thank you so much. And you can go to the next slide, please, because that's just reminding me how bad I look today. Anyway, thank you so much, everybody, for joining. We have great representation from across the country. I'm looking at it: Georgia, Wisconsin, Minnesota, Saskatoon. I just love saying that. New Jersey. Really great to have everybody joining us today for this important conversation that we're going to have on the opioid epidemic. But before we get to that, just a little bit of level setting. We are PFCC Partners. We are an organization that supports health systems, research teams, measure developers, anybody who is interested in partnering with patients and families to build the infrastructure for authentic and high value and sustainable partnerships with patient family advisors. Next slide, please. One of the programs of PFCC Partners, and I think this is really important for advisors to understand, the PFAnetwork, which you are members of, and hopefully I think we have a few facilitators on, and hopefully your advisors are members of, is a program of PFCC Partners. And the network was developed really in response to the just explosion of patient and family engagement opportunities, and really being understood and valued as a highly valuable strategy for reaching the improvement that we wanted to see. And so we felt along with several advisors that we'd been in touch with, that creating a sense of community around what the role of advisor is and does, and what those commonalities are was really important. Continuing to raise the capacity of advisors to be able to, be well prepared and have the context for strong partnerships is part of why we developed the training programs and the skills exchange component. And then finally, we, as many of you on the call know, because we've connected with engagement opportunities across the country, we're consistently getting requests from all kinds of healthcare professionals, whether that be a national organization like NQF or a regional research team or a quality improvement organization, folks looking for patients and families with particular lived experience to engage in their projects. Again, we're getting more and more every week requests for that. And so we wanted to serve in that matchmaking role to be able to get all of you out there in the environment using your voice and partnering, and also to get the organizations, advisors who are skilled, have that capacity building to move forward. So on the next slide, you'll see that the PFA network really is our foundation. I come to all of this work from the perspective of a patient-family advisor. Most of you know I've served in that role since the mid-90s, and I've learned a lot the hard way, and I'm just trying to shorten the learning curve for everybody else. But everything we do still comes from the patient-family advisor perspective. And then you see in those two orange boxes the two lanes that we support partnership across healthcare. One is to build the infrastructure within organizations, and the other is to support all of you through the PFA network. So again, I think it's important that you as PFA network members and representatives of the PFA network really have a good understanding of how this coordinates with PFCC partners. So, any questions about that? And please, I encourage you, if you forget to take raise your hand, take yourself off mute and speak up. This is a conversation. Any questions about how the two go together? All right, well then we'll just keep on moving because I know we've got a lot to get to today. So this is exciting to me. When we started the PFA network about 6 years ago, we had 25 people. And now we have grown to over 600 in the database. We have, these pins are demonstrating where people are. So it's not the person, it's not the individual, but it's where we have some coverage. So it's exciting to see that we really are starting to get a strong national presence. We have some work to do up in the Great Plains area, but I know we have a wonderful Quinn QIO up there that is working with people. So again, we really are starting to get that national coverage and be recognized for having that kind of capacity. Next, please. We want to welcome our new patient family advisors from the last month. We share and are so excited to welcome these guys into the Patient Family Advisor Network. These are all people who are serving in the role of advisor across the country. We've connected some to some of the national projects that I mentioned, but this is the growth over the last month since last we met. So really excited to see this continue to grow. And I see, I'm going to call out Brandy Hicks. I saw her name from Lawrenceville, Georgia. Thank you so much for joining us, Brandy, and for joining the call today.
Hi, thank you. Happy to be here.
Excellent. There's a lot going on in this office today. All right, next slide. Welcome, everybody. Here is the Yammer community. For those of you who have not joined online yet, this is where we can have conversation in between these virtual meetings. This is where we update the work of the work groups. And I know a lot of you have been very active on here, sharing resources, sharing upcoming meetings and conferences, webinars. I love how this is working out, and I hope that it's working out for you. Let me just stop there and see. I know Janice and Harvey, you both are big contributors on the Yammer community. I just want to find out if it seems to be working for all of you to utilize this for a resource area. Any comments?
One comment I would have is join.
Great. Joy, I'll take it. That's wonderful. Well, thank you so much for all your contributions, Harvey. It's been great to see you active there. Any other thoughts? All right, moving on then. Next slide, please. Oh, there we go. So today we have not a guest, a member of the PFAnetwork, Patty Black from the Seattle, Washington area, is joining us today. And Patty and I had a really important conversation about opioid use and the response to the opioid epidemic in the country. And I think Patty brought up some really good points, some of which we thought about in the PFA Summit last summer, and some that were kind of new and a new opportunity to have voice. And I think there's so much work going on the opioid crisis in so many different areas. Everything from, I got an email from some medical students that are interested in developing a program, all the way to National Quality Forum and the National Academy of Medicine. So there's so much work going on, and I just think it's really important that we as an advisory community have a strong sense of what this epidemic is looking like to all of us as patients and as family caregivers. So Patty, could I invite you into the conversation to share a little bit about your experiences and your perspective on this?
Sure, Libby, I'm happy to. Just to give you a little bit of background, I'm a provider shadow coach, and I have the opportunity to be able to sit into patient and provider visits all day long from many, many different specialties, mostly primary care. And so when I share with you that I have an opportunity to see and hear conversations around opioid pain medications, I understand that there truly is an epidemic, and we as citizens in our country, we need to pay attention to that, and we need to help our healthcare providers deal with this. However, I do see people who really do need to have some help around pain medications. I also see people who, quite frankly, and I know I'm making a judgment statement, that are really seeking pain medications. Maybe they, for whatever reasons, but maybe, I guess I see a lot of people who are presenting what I would call Academy Award winning performances. For whatever reasons they do that. But I do see people who are in dire need of pain medications, and they don't seem to be getting the help. And so my call out to Libby and to the rest of this group is, what can we do to raise the awareness to people in healthcare today in our country to say, maybe it's a good time for us to start having conversations for those people who are not seeking drugs just because they're addicts. That there is true reason, that they're experiencing great amounts of pain. I think we have an opportunity to talk about how we can support maybe pain management as a specialty. And I know that's starting to happen in different settings. Maybe we can lend our support to say, we want to support this. Let's see if we can't put more money into it, or whatever it is that we need to do. I can share many, many stories with you about the need that I see, but I can speak now because one story in particular hits very close to home. I have a niece who has a lot of significant healthcare issues. One of them being she's a hemophiliac and many, many factor deficiencies. And as such, over the course of her lifetime, she has had to have many, many infusions, which has caused her joints to be, for a non-medical term, squishy and mushy. And so now what she's experiencing is a lot of her joints are giving way. Ribs are popping out, hip muscles are giving way, her hip joint will pop out, and it's painful. So she has, as you would imagine, many healthcare providers, not just primary care physician, that she goes to. Of course, they always ask her, how are you feeling? And she, being taught to really speak up very tactfully, but to share what she's experiencing, she shares, I am in a lot of pain. What can you do to help me with it? So this is a problem, and it's a good thing that records are being shared throughout, that we have a team approach to encompass people with different healthcare issues. But now primary care physicians are looking at, and again, important to do this, where are other people seeking help? Are they going to different pharmacies, to seek help with medications? Are they going to different doctors? Are they really, truly seeking medications, maybe not so much to alleviate pain? That's still a good thing to track. But what's happening to a lot of our patients is they're being dubbed pain medication seekers, drug addicts. And so they're starting to be dismissed from practices. And that's happening to my niece. She's gone to a primary care physician, and the physician's doing due diligence with her. She's bringing up alternative ways that my niece could perhaps deal with some of her pain. One of them is that she's been suggested to go to an acupuncturist and go to a chiropractor. Well, aside, her insurance doesn't pay for either of these, but her family has said, okay, well, we'll see. We'll give you the money to go. Let's see what they can do. Well, in my niece's case, she's finding out that these other care providers are putting their hands up and saying, whoa, we're not touching you. Your healthcare needs are too severe for us. We don't really know what we're doing, and you're too risky. She's also been given exercise. This is kind of a funny story if it wasn't so sad. She was giving a handout, in fact, 2 or 3 handouts from a couple of her doctors saying, we want you to go to physical therapy and we want you to do these exercises. So great. She goes to the physical therapist and they look at her and they say, where did you get these exercises? She'll say, well, from my physicians. And they look at her and they say, well, these are for exercises for people who could walk. I didn't mention my niece is in a wheelchair and hasn't walked for a good 10, 12 years. She can't even stand up without help. So it's these kind of experiences that aren't getting in our patients' records. There's more of a story than perhaps what's there. So make a longer story short, she went back to her primary care physician and she said, I'm not getting help. This isn't working for me. And so she's been dubbed as non-compliant, and she's been dismissed from her primary care practice. Well, in her particular healthcare organization, if you're dismissed from one primary care physician, you're dismissed from all of primary care. Now, this is not a story that is just our family story. This is happening in lots of other places. And understandably, again, we need to do something about this opioid crisis because there is one, but maybe the pendulum has swung a little bit too far. Maybe we need to go back and we need to say, what can we do to raise our voices about the concern that we have for people who indeed need help with pain management? So that's my ask.
Patty, I am just so sorry that your niece and your family has experienced this, and but I think you're bringing up a largely overlooked effect of the swift response to the opioid crisis that I think perhaps needs to be voiced. So I just want to open it up. Looks like Joan Maxwell, you have your hand up. Any reflections? Any?
Yes. Thanks, Libby, and thank you, Patty, for sharing that story. On a personal note, I have a brother-in-law who is addicted to opioids as a result of 2 failed back surgeries. And so I'm very passionate about this topic. Also, for the past year, I've been on a committee with IHI that is focused on post-surgical opioid use and how that can often be the trigger that sets someone down the path. And so we're doing some good work, I think, and it will be presented in May at the IHI conference in Houston. But just to summarize part of it, and it's focused for kind of patient safety heads at hospitals, for them to kind of lead the charge and get everyone coordinated, because, you know, you mentioned, Patty, that this is needs coordination between all the doctors when it's a complicated case, like in your family's situation. And I personally have also found that to be a challenge. But one of the things that I'm really trying to advocate for is to get doctors to have conversations with patients about this in advance of surgery, for example, or in the doctor's office, spending enough time to really let patients know what their choices are and what their trajectory is and what might happen. So in the case of a planned surgery, for example, rather than, you know, waking up and being on IVs and one of them is an opioid and you don't know what it is, or I've been given prescriptions before surgery to fill that I didn't know were opioids until I became more educated about this. I think we have to really start with the basics, and that's the communication, and having that communication happen as early as possible in anyone's journey, and letting patients know, you know, here's what we're going to do post-surgery. We think you'll be on the IV for 24 hours. After that, we can switch you to oral pain meds. It will be this medication. It is an opioid. We estimate you'll need it for X amount of time. Then you can take Advil. I mean, a lot of studies show that Advil and Tylenol are as good as a lot of these opioids. So there's just so many opportunities to kind of make this better. But I think we have to get, I don't know if it's CMS or insurance companies involved, because a lot of the things that helped me were not, you know, things that are paid for by our providers. And so if you want to, opioids are easy and cheap, and that's the truth. And it's, to some extent, I do feel like this is all about the money. And so unless we get some of these other things paid for by insurance, I think we're going to continue to struggle. So I do think that's an important point also. Anyway, I could talk about this for an hour, so I'll stop and let other people contribute. But I really appreciate everything you said, Patty, and I think this is something that as patient advisors we should focus on.
Let me just ask a clarifying question. In your work with IHI, you've been on that project for a while now, and I know you've also done some work with National Quality Forum. In those discussions, has this sort of scenario that Patty described come up in terms of those who really need the opioids being restricted from them?
Yes, there is concern about that. It definitely comes up, and you know, they eliminate people, you know, who have cancer and people who are at end of life, you know, but unique situations like Patty's, I don't know if they can kind of fall through the cracks. I don't know about that. And I'm not sure there is enough emphasis on it, but certainly, yes, it does come up, and there is an awareness that we have to be careful not to swing the pendulum too far.
I appreciate that, and I would open it up to others on the call to think about how unique is this? My guess is it's not as unique as we think. I know that cancer gets carved out quite often, but there's a lot of people out there living with chronic illnesses that include a lot of pain. I'm thinking about our, I just lost it. Anyway, a lot of chronic pain going on out there. So any others or other thoughts? Or experiences, I guess I should say.
You know, I think there just needs to be a lot more education around it. You know, in my niece's clinic, there are a couple of pain management doctors specifically, you know, to help people through pain. And my niece had asked her primary care physician, you know, could she be referred to one of those doctors? And she said, in fact, I am willing to sign what now you see quite often is a pain management agreement that a lot of us will ask our patients to sign. She said, I'm willing to sign one of those. And her primary care physician said, no, I'm not going to refer you to that. I don't think it's needed, and then turned around and dismissed her. So it's just a real hard place to be in, you know, and looking at it from the clinician's point of view, you know, they can get themselves in trouble if they prescribe. They have to make a case for being able to prescribe now. And so it's just really, really difficult. Now I can share another story myself. This was about me, gosh, maybe now 10 years ago, but I was experiencing some excruciating amount of pain due to an autoimmune disorder that was ravaging my whole system. In fact, I was told at the time that I probably had a year left to live. And I, at the time, of course, you know, when you have all this pain, you don't sleep, you don't function, and it just wears you down. Well, there was a time after going through this for a couple of months, I was really thinking about, you know, maybe I need to end it all. And so not sharing those kind of, because I was embarrassed about it. I didn't share that with my primary care physician, but I was also at the time being prescribed an opioid, and I learned firsthand that they're not that well. They help people, but for me, I noticed that I was prescribed to take one every 6 hours. And then I needed it every 5 hours, and I needed it then every 4 hours. So it was not working. So I made an appointment with my primary care physician, and I wanted to share, we need a plan B. This is not working. And as soon as she came into the exam room and I said the word pain medicine, I saw a finger go up in front of my face and shake it and say, you just suck it up. I'm not giving you another pain med. I have never been treated like that in my life before. I was so stunned, I couldn't respond. But it's that knee-jerk reaction that so many of our providers have around the conversation with opioids. And we've got to somehow be able to change that, to be caring and compassionate about it.
I agree. So, Kristen, you have some interesting ideas in the chat box. Are you able to speak up, and what kind of scripting could we support, do you think, to help providers to be that bridge? Because I agree. I think that's exactly what Patty's describing is how do we get our clinicians to help be a bridge and instead of seeing this issue in such black and white terms?
Hi, this is Kristen. I wanted to just share, Swedish Health System has been working on a chronic opioid pathway, and we have a multidisciplinary team that has been helping us provide tools for especially primary care providers, but also specialty in terms of how to not only manage the the chronic opioid therapy, but maybe some of the language that would allow patients to engage in their care. One of the things that's difficult in our current system is there's more measurement going on of how many opioids are prescribed and that type of thing, but the thing to keep in mind is it's still the responsibility not to abandon a patient and to make sure that we're providing adequate care. And Washington state laws in particular, the new ones actually say that good care also means that you are providing care. You can't just not provide care. And so some of the things we have come up with are some tools that have language that might be more of inviting the patient into providing feedback, using a tool like the Pain, Enjoyment, and General Activities questionnaire that helps track over time how has this helped or has not helped you, and brainstorm together what solutions might be. And then for chronic pain, we have something called the Structured Functional Restoration Program that our pain specialty runs, and it's also a multidisciplinary program that certain patients are interested in engaging in and has been quite successful. I think where the patient voice might come in is we could help as we look at experience, the poor experience, and say, okay, we've identified poor experiences. What would be some language from the patient perspective that would have invited you into finding solutions or giving your providers information that might help move to from like a binary, oh, you're a drug seeker or are not a drug seeker, to what are some solutions that we haven't tried yet that we could then now try? Because anyway, that's kind of what I meant. I don't know if that helps.
It does. Thank you so much. So, Kristen, are you a patient family advisor, or what's your role at Swedish?
So I am actually a system quality program manager who I'm coordinating patient family advisory work, and one of my other jobs is to facilitate our pain and opioid management pathways. And so we have a longer term goal to move our needle from where we are now with managing pain to a future state that that engages our patients more in solutions and helps them understand how best to contribute to their own care experience, and then conversely for the care teams to know how to best partner and invite patients into their care. So I have maybe a unique perspective, but I've also been a patient, and I understand some of the struggles that that one might have after surgery. So.
Well, I really appreciate you joining us today. So were your advisors then informing the development of your communication tools?
So we are, I will humbly say, just rolling into a more robust patient and family advisory. So we are bringing some of our materials to a PFAC actually next week.
Great.
And so to date, we have had maybe one patient here or one patient there give some feedback, but we're wanting to bring it to a council now. So
good for you. Good for you. Well, that's great. You're rolling on it. And I just think it's so important anytime we're thinking about communication, and whether it's around opioid or other information, anytime we're helping clinicians to communicate, it's just so valuable to have your actual patient population informing that kind of communication tool. So good for you. Others, Charlene, let's see, what do you, yeah, how to stop the pain medication if they do need to continue it, and have that conversation way outside the opioid use, I think is really important. So I'm kind of hearing a couple of different things. Let's see. Oh, cool. IHI has a script. Great. Joan, if you would maybe post that on the Yammer community, or we can send it out and follow up to this call, that would be great.
Sure, I will.
Excuse me. So I think that what I'm gathering from this conversation is it is important for us to have, us being the community of patient family advisors, to have a voice in this work, and be able to shine a light on some of the things that we have concern about, like folks who need pain management. What I'm hearing, I was kind of jotting down a little radius of ideas that I heard, and also with other work that we've been doing in the opioid space. As maybe some of you know, I lost my sister to an opioid overdose 4 years ago. So this is really personal, and I think it's personal for almost everybody on the call, because at some point or another, folks are dealing with this issue. So what I've heard so far is, starting way upstream and having good communication about opioid use if it's anticipated, either following surgery or what have you. And that good communication may include, how much is going to be used, how long to expect that it's going to be needed, and how we're going to move off of it. So all of those pieces way upstream in communication. And then there's this whole concept of safe prescribing, which is our clinicians being very studious or good stewards, I should say, of opioid use. And what does that look like? What are the parameters for that? And I think, there's so much research going on. Sorry. There's so much research going on currently about what those guidelines can look like, and hopefully we've moved past the days of I had my gallbladder taken out last year and was prescribed 100 opioids to go home with. I didn't need 100 opioids. I took one. So hopefully we're moving past that with these safe prescribing guidelines, and then there's this whole pain management in the broadest sense of the term, and that includes I think the term is not alternative anymore, but I can't remember what it is, but things like chiropractic and physical therapy and all of those things. But then we have to manage the payer mix, and how do people actually access those, the interdisciplinary teams, and I love that pathway, pain management pathway. I think that's a really great way to describe it, because it could go in a number of different directions. So that whole broad-based pain management. And then I think we go into folks that have opioid use disorder, which is the sort of acceptable term at this point, that is judgment-free. So those who are experiencing opioid use disorder, first starting with harm reduction. How do we make them safe? How do we keep moving down the path to moving them out of opioid dependency? The medication-assisted withdrawal is something we're hearing much more about. This is something NQF is taking on. So where does that fit in? And then also, and I guess I would say finally, I'm not sure that this is in a stepwise process. It might just be more of a splatter, but finally, the use of Narcan and life-saving for folks experiencing opioid use disorder. Have I missed any concepts that need to be kind of woven in here for us?
Libby, Libby, this is Joan.
Hi.
I put this in the chat box. At the IHI meetings, there was someone representing pharmacists, and she just had a really interesting perspective on how pharmacists could be of help, especially in complex cases where there's multiple doctors involved. But they know a lot about prescribing, and I think it just would be interesting. I don't exactly know how it could all fit together, but I wonder if there could be a role for them to play.
And I feel like they're so often overlooked in the traditional sort of interdisciplinary team. So,
yeah, I really think it's just worth exploring, or if there's a discussion, having someone, having them represented.
Sure.
I agree. This is Patty. Mm-hmm. I think, Joan is hitting on the who. I mean, who else out here in our world can help us? Would it be CMS? Would it be the pharmacist? Would it be, the payers? I mean, that's, we've got to have that support from all of our insurers to support some of this work, I would think.
This is Mary Casillas. I completely agree with the pharmacists and working with them to come up. I agree. They are underutilized and they have such a knowledge base. I think it's not just the opioid, it's a lot of issues with drugs that we need to partner with pharmacists to overcome. And personally, my own experience, my dad was admitted last year into the hospital with many issues, and come to find out everything he was admitted for, all his symptoms were the cause of a drug that he had been prescribed for 15 years.
Oh, wow.
And it was picked up, number one, by a nurse and it was because she took the initiative to go to a pharmacist and said, can you look at this drug list? And the pharmacist said, why is he on this pill, number one? And why is he on this dose? He was on a completely wrong dose, had been for 15 years. Wow. But it was that pharmacist who then went to the physicians, I say plurally, and worked with us to get him off that drug. And it was replaced by CBD oil.
Excellent.
So it's very interesting how we tend to not utilize, I think, pharmacists the way we should.
I agree, and I think that in particular, if we're looking for partners, that would be a wonderful way to go. And we have some good connections with the, I don't remember the proper name of it, but basically the American Pharmacy Association. That might be the name of it. Anyway, so we can definitely pursue that. I'm catching Charlene's comment in the chat box as well that automatic renewals, especially for our older adults, may also be a problematic. So I'm going to capture that in what I said before.
And Libby, this is Lindsay. I was just thinking when it comes to payers, they're kind of impacted by how opioid use or opioid prescriptions are measured. And I know that that's something that has been talked about, and we're talking a lot about meaningful measures and patient-centered measurement. So I think that's also a great place to start, is how are opioids and the prescriptions and other alternative forms of pain management being measured.
I love that. And yeah, we heard from our CMS colleagues how important this whole area is. So perhaps this is something we can inform what a patient-centered measure might look like for opioid use.
Yeah.
Yeah, agreed, Charlene. Okay, so
I just had something to contribute. Here in state of New Jersey and Pennsylvania as well previously, the pharmacists and the physicians, and in my field, retired from dentistry. Our dental society recently had a speaker, Tom Viola. He travels around the world and speaks at just about every annual dental society, American Dental Association meeting. One point that Tom brought up was that opioids are being introduced at a young age to people, more specifically in the dental field, when they are having a tooth extraction for their wisdom teeth. And state laws here on the East Coast that I'm aware of are limiting the amount, no automatic renewals. And he even, as a pharmacist himself, and I have taught with Tom, in the past,
Mm-hmm.
is very much advocating for knowledge. The American Dental Association requires it as continuing education in every state, no matter where you are in the United States. So I see, people saying this isn't happening and that isn't happening, but being on the professional side, even being retired and still active in the dental community and the dental societies locally, they are. Many years ago, I had a patient who was a physician, and before he went to medical school, he was a pharmacist. But currently, today, he is in jail. He was writing scripts. He was selling scripts right out of his practice as a general practitioner. And it was a big surprise to me over 20 years ago to look on the evening news and to see him in an orange suit and handcuffs. That was over 20 years ago. So the opioid epidemic is not anything new. It is reached epidemic proportions throughout the United States, throughout the world.
Mm-hmm.
And people who are going to misuse and abuse, because I did also teach college students health education classes, misuse and abuse will find it anyway. I've had patients come walking into my office when I was practicing, and before I knew it, I knew what this guy was looking for when he was complaining about TMJ pain.
Mm-hmm.
And when I came back after taking a radiograph of the appropriate area, he disappeared. He ran out of the office. I got on the phone right away, and I had already given him a referral to an oral surgeon. I got on the phone and called the oral surgeon, and I said to him, I said, be on the lookout for this guy. This is what he looks like if he shows up at your office. I got a call about an hour later. He said, Harvey, the cops were here at my office, and then they arrested him. Because he claimed he was from another state. He was, in Philadelphia at the time. He ran out of his medication. He showed me the empty bottle, and,
So I think that there's so much to be said about that, and what people who are experiencing opioid use disorder obviously do not have the ability to have good judgment. My sister certainly didn't, and that's part of the illness. So I'm not really supportive of criminalizing the behavior, but what I would like to see us do as a community is have voice. There is, as you said, Harvey, so much work going on to address the opioid epidemic. But I just want to make sure that the patients and the families are having a voice, regionally and nationally in some of those programs. So with that said, and Janice, I appreciate what you have. I think that's what I've been scrapping out on my paper. So I'll try to put that together a little bit more of on a graphic. But is this a conversation we want to continue as a network of patient and family advisors? The avenue for us to do that, as with other important topics that we've addressed, is through developing a work group. So is there interest from those of you on the call here, and we'll ask it again in the newsletter and on the platform, but let me ask here, is there interest in starting a work group to organize our thoughts about the response and communication we want to have on the opioid crisis?
Yep.
I would love to be included in that, Libby.
I would as well.
All right. So
or anybody in the pharmacology area would be a plus.
Yeah, I agree. I think what's important, and I do agree with that, I think what's important is that we as a community sort of gather our thoughts and organize ourselves. I don't know, do we invite pharmacology into that conversation? Maybe that does inform us in a different way. Or do we kind of get our ducks in a row a little bit before bringing in others? I don't know. What's the preference there? Any thoughts?
I guess this is Joan. I'm kind of wondering, what if we did a little bit of each? In other words,
Has already had the pharmacist last year speak about it.
I'm sorry, can you repeat that? Who was that? Somebody just mentioned the pharmacist last year, but I didn't catch the whole comment. Could you repeat that?
I think what I heard Joan say was a little bit of each.
Right. Okay.
I guess, Libby, what I was thinking was maybe we, just would meet quickly 1 or 2 times to kind of identify, like we started to do on this call, some ideas for brainstorming, but that we bring in kind of the other people and really see it as a very open kind of no bad ideas, brainstorming with, pain management person, a pharmacist, would be great to have a diverse group of people to brainstorm. That's just an initial thought. But I'm open to whatever the group decides.
Yeah, I would agree in bringing in palliative care doc.
Right. Right. All right. Well, we've got a direction to go in, and I'm really glad about this, because I do feel like with all of the work that's going on, I think there's patients and families involved in a lot of it in different places. But I think the opportunity we have in the network is to kind of create a consensus message that represents the community as a whole, and to be a little bit louder. And so I'm really excited that you guys are interested in taking this on. I'm guessing that as we put this out to the broader community, we'll have many more at our sides. I would ask you if you are interested. I think we caught the yeses on the call, but if you decide later on, please send us an email. And as well, if you have connections to those kinds of folks that we've been describing, the pharmacists, the palliative care, the alternative pain management folks, I would be really interested in connecting with those and inviting them into our process as well. So more to come on that. Sounds like we'll launch another work group, and we'll get busy on that. All right, I'm going to move us through in the last couple of minutes a few quick conversations. Let's see. I just wanted to share with you that Lindsay and I and Stephen and our colleagues at the National Coordinating Center for the QIOs, we had a wonderful knowledge cafe with advisors from across CMS programs. So advisors that were serving in the quality improvement organizations and the end-stage renal disease networks and the transforming clinical practice initiatives and the hospital innovation improvement network. We had advisors from all of those different programs, along with a few facilitators, staff facilitators. And together we kind of looked at the current dilemmas in the environment and what recommendations or resolutions we could brainstorm around how to move patient-family engagement deeper into our health system in terms of really, again, deepening and strengthening the partnership. Sorry, I got distracted there. So there's more to come on this. We're just sort of compiling all of the wonderful input that we got. We got it individually and then small group. we'll put this into a document, and that'll be coming out to you as well. So those kinds of things that you can use in your own local partnership efforts to kind of connect to what's going on nationally and really support and validate the work that you all are doing locally. All right, next slide, please. National Health HIT PFAC. Lindsay, we are so short on time, and since we haven't met with this group last month, we'll
talk about it next month.
Yep, but basically the thing going on here, and you can see and have your input, is we are designing a perfect patient portal as designed by patients and families. So we certainly want all of your input and your ideas, and I know you all have them. So that conversation's going on in the Yammer community as well. Next, the 2019 Patient Family Center Care Conference. Oh my gosh, what a day. Anybody on that was there besides Lindsay and I?
I was there.
Janice was there.
Oh, Janice was there.
Did you have a good day,
Yeah.
Janice?
I had a great day. I felt this was really impressive, and Desiree and I shared lodging, and we both talked about how great it was, and I'm still thinking about it afterwards. I was engaged and didn't get tired the whole day. I usually kind of tired halfway. So I just want to thank you. I felt it was very, very engaging, and I learned a lot, and I met somebody from Seattle there, from Seattle area, which is in Washington State anyway. So thank you.
Absolutely. Thank you for making the trip and joining us. So I thought, my father-in-law every year says this was the best turkey ever at Thanksgiving every year. And I feel like the same thing with the conference every year. This was the best conference yet.
Mm-hmm. Exactly. I don't feel it's fair to say that this is better than last year, but I really think it was. I even presented last year. So, but I just felt I understood more about it. I felt there was more actionable opportunities. I think that's what I want to say. That's something I can follow up and learn more on. I'm sure there's other people that were there.
Great.
Thank you.
Absolutely. Thanks, Janice. So yeah, we had a great day. Lots of good connections made. This conference is a little unique in that it's not a showcase conference, but rather it's just as Janice was saying, it's something really concrete that you can have takeaways with. The breakout sessions, all 16, are presented with healthcare professional and their advisors on the particular program that they rolled out. So this year we were very fortunate to have Paul McGann and Dennis Wagner from CMS join us for the day, and they stayed the whole day to really just interact and understand what people are working on in patient-family engagement and share their perspective of it as well. So it was a great day. I hope that all of you will put the 2020, oh my God, that sounds weird even to say, 2020 conference on your calendar as soon as we figure it out. It won't be the day after Super Bowl again, I promise. It was great. Let's see. All right, next slide, please. Compensation work group. It's another work group that this network started to address how we compensate patient-family advisors for their efforts. Do we compensate them? What does that look like? Is that cash? Is that help? And how is that tied to getting disparate voices represented in advisory work? So still working on a set where we finished the environmental scan, and now we're moving into creating a set of recommendations. We've requested resources, of which we've gotten quite a few, and we'll be ironically pursuing funding for that work group so that we can keep that work going forward. Next slide, please. Bill, I wish there were travel and lodging scholarships for the conference too, but I think I think what we can do is go forward with more sponsors for next year and see if we can get that done. It's always kind of a catch-22, Bill, I'll tell you, because part of it is that we want the organizations who are engaging patients and families to invest in bringing their advisors with them. And that's the model that most advisors get to the conference in. And we feel like that's a really strong model, but we also recognize that others may or may not have that kind of connection and need that additional support. I welcome your thoughts to that, Bill. In terms of engagement opportunities, I will call out the California Quality Collaborative. If we've got anybody on the call that is in the Inland Empire area of Southern California, we're looking for an individual to speak with the Transforming Clinical Practice Initiatives out in that area. So if you're interested, you can just contact Alex Stack directly. That's her email is right there. We can also post this on Yammer. All right. Ooh, I'm 2 minutes over. Next. I think that's it, and we don't have any time for questions. Great discussion today, Patty. I want to thank you for calling in the first place and sharing your story with me so that we could raise this on today's virtual meeting. It is an important topic, and it's an important topic for us as a community to have voice in. So thank you for bringing this to our attention and for sharing your experiences today. And thanks to everybody else who contributed.
Yeah. Thanks, everyone.
Thank you.
Thanks, Patty.
See you later.
Have a great day.
Bye-bye.
Bye.